Experiences for you to try. Exists for you to try. We're making our sites better for you to see. Better for you to see. Cooking up new dishes for you to taste. Dishes for you to taste. Good for you to try. And cultural discoveries for you to feel. For you to feel. We're not stopping. We're not stopping. You deserve more. You deserve more. For you to wait. For you cultural discoveries. For you cultural discoveries. For you to we're not stopping. We're not stopping. Every day, the Philippines does more than wait. More than wait. We're not stopping. We're not stopping. Adventures. Adventures. Philippines does more than wait. Philippines does more than wait. Exists for you to try. Exists for you to try.
是那个润的软体有问题，是那个润的软体有问题，这个密程没有问题。
Cooking up new dishes for you to taste. For you to taste.
这可以关了没？这可以关了没？
We're not stopping. We're not stopping. They deserve more. They deserve more.
这可以关了没？这可以关了没？
We're not stopping. We're not stopping. Every day, Philippines does more than wait. Philippines does more than wait. Together through adventures. Together through adventures. Every day, Philippines does more than wait. Philippines does more than wait. Experiences for you to try. Experiences for you to try. Making our sites better for you to see. Making our sites better for you to see. Cooking up dishes for you to taste. Cooking up dishes for you to taste. For you to try. Cultural discoveries for you to feel. Cultural discoveries for you to feel. And we're not stopping. And we're not stopping. That you deserve more. That you deserve more. To welcome you cultural discoveries. To welcome you cultural discoveries. We're not stopping. We're not stopping.
Aduh pusing. Bondol. 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 Ano? Benar-benar.
Hello, everyone from Asia, and to all our audiences around the world. Hello, everyone from our friends in the Philippines. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies, and hosting the 50th CPD Asia program is the Philippine Association of Radiologic Technologists Incorporated. And I'm Peachy Luna, CPD Asia Secretary General, and your CPD Asia program host. We are live streaming on YouTube. Just search MSR or PARI or the VART channels. You can join us live or watch the replay anytime. So to formally start the program, may I call in Part President Ruben Lorenzo for his welcome message. Sir, are you here now? Yes, sir. Sir. We can hear
Hello.
you po. Yes, we can hear you po. Yan, we can see you po.
Hello. Hello, good evening. It is my great pleasure to welcome you to the 50th Continuing Professional Development Asia program, a fully online gathering that marks a meaningful milestone in our shared pursuit of excellence and growth in the field. This 50th session is more than just a number. It represents sustained commitment to lifelong learning and professional advancement across Asia. We are especially thankful for the valuable collaboration of the Society of Medical Physicists of the Republic of the Philippines under the leadership of its president, whose support and dedication have helped bring this program to life. On behalf of the Philippine Association of Radiologic Technologies, I thank you for joining us. Let this program be another step forward into our journey as health professionals, empowered by knowledge, connection, and innovation. Mabuhay and maraming salamat po. God bless.
Thank you so much, Part President Ruben Lorenzo, for that message. As we have just heard, we are gathered today under the inspiring theme of precision, protection, and progress, enhancing radiologic practice with medical physicists. This theme captures our shared pursuit of excellence through collaboration and continuous learning, especially between radiologic technologists and medical physicists, a partnership that advances both safety and innovation in healthcare. Before we begin, let me take a moment to extend our heartfelt appreciation and warmest welcome to all presidents, officers, organization representatives, and panelists joining us from various radiologic societies and institutions across Asia. Let us greet and welcome Vice President Dennis Yuchin Shun of the Macau Radiological Technologies Association, MRTA.
Hello, everyone. I'm the Vice President of MRTA. Welcome all of you join the CPD. Thank you.
Representing the President of Perhimpunan Radiographer Indonesia, Indonesian Society of Radiographers, PARI, Dr. Giek Subianto, we have here our panelist, Adi Putu Susanta. Yes, hi, Indonesia. We also have President of Vietnam Association of Radiological Technologists, VART, President Thai Van Loc.
Hello everyone. Congratulations 50 Asia CBD to try very nice the number. Thank you. Congratulations Philippines. Thank you, BC Luna. Thank you, President Group Band. Thank you very much. Thank you very much.
Thank you.
Thank you, President Ivan Locke. We also have President Mr. Nang Tat Ming of Hong Kong Radiographers Association, HKRA.
Good evening, everyone. Welcome to the 15th Asia CPD, and hope you enjoy in this evenings for the Asia CPD program. Thank you.
We also have here President of Malaysian Society of Radiographers, Mr. Sawal, President Mr. Sawal Marsait.
Hello, good evening. Congratulations to PRT for the 50th CPD ASIA, and I hope everyone will take home that very good message that's shared by the Philippines. Thank you.
Thank you, President Marsait. We also have President Denise Chung of Singapore Society of Radiographers.
Good evening, PG, and welcome everyone to the 50th CPD Asia. Thank you very much to PART for tonight's talks. I'm looking forward to it.
We also have thank you, Ma'am Chung. We also have President Vitarana Gamejue Malasen of Society of Radiological Technologists, Sri Lanka.
Hello, good evening, everybody. Congratulations to Philippine Association of Radiological Technologists. Congratulations for this 50th CPD Asia program. Thank you.
Thank you, President Vimala Sena. And we have received greetings from different presidents. We have from President Chuan Yu Tu of Taiwan Association of Medical Radiation Technologists. Oh, I think we have here also a president of Taiwan Society of Radiological Technologists joining us live, President Hui Yuan Wo.
Okay. Hello, Pichu, and all the participants. I'm the president of Taiwan Society of Radiological Technologists. I'm glad to have this opportunity to enjoy the meeting with all of you. Thank you.
Thank you, President of TWSRT. And now we also have received greetings from President Sophie Lee of the Association of Cambodian Radiological Technologists. Greetings also came from President Muhammad Abdul Ghani of the Palestinian Association of Medical Radiation Technologists. And also we have received greetings from the President of the Indian Society of Radiographers and Technologists, President Mr. Mohan Lal Bhagwat. Also from President of Japan Association of Radiologic Technologists, Mr. Katsuhiko Ueda. Joining us also as our panelists, we have Sir Nelson Wang of HK, yes, ARA. We also have Madam Chan Lai Kwan from Malaysia. And
hello, greetings to everybody.
And the immediate past president of ISRT, Sir Selva Kumar. Okay, so before we begin the session, may I humbly request all presidents and officers, panelists, representatives, and also our speakers who are already here to kindly turn on your camera for a brief photo session. All right, thank you very much, Paul. It is my absolute pleasure to introduce the remarkable lineup of speakers who will bring today's theme to life with expertise, experience, and vision. Let us welcome each of them with our undivided attention and appreciation as we begin the enlightening session. So to begin our scientific session, we are privileged to be joined by a medical physicist who champions safety, learning, and continuous improvement in clinical imaging. Ms. Maria Vanessa Francesca P. Perianes is the Chief Radiation Protection Officer at the Medical City, where she applies her expertise in maintaining high standards in radiation safety and regulatory compliance. She obtained her Bachelor of Science in Physics from De La Salle University and is currently completing her Master of Science in Applied Physics or Medical Physics at the University of Santo Tomas Graduate School. A passionate educator, she also serves as a professional lecturer at the De La Salle University, actively mentoring future generations in physics and medical sciences. Today, she will share valuable insights through her talk, Quality Assurance in Radiology, the Critical Role of Medical Physicists, and Essential Insights for Radiologic Technologists. Please welcome Ms. Vanessa Perianes as she explores the systems, partnerships, and responsibilities that drive excellence in radiologic practice. Ma'am Vanessa?
Good evening, everyone. We're going to explore a topic that is foundational to patient safety and diagnostic accuracy in our field. Quality assurance in radiology, the critical role of medical physicists, and essential insights for the radiologic technologists. We will discuss the roles of medical physicists and radiologic technologists and how their collaboration is absolutely important for delivering the highest quality of patient care. I am Maria Vanessa Francesca P. Perianes, one of your speakers for tonight's CPD Asia. So to truly understand the weight of quality assurance in radiology, let's start first by asking why quality assurance matters or why QA matters. First, it's about patient safety. We are dealing with ionizing radiation, and while it is diagnostic and therapeutic tool, it must be managed with care. QA ensures we're consistently minimizing radiation dose to our patients, adhering to the ALARIA principle as low as reasonably achievable. It also prevents errors that could compromise patient safety or patient well-being. Secondly, image quality. A blurry, noisy, or distorted image isn't just an inconvenience. It can lead to misdiagnosis, delayed treatment, or even unnecessary follow-up procedures. QA protocols ensures our equipment is producing clear, consistent, and diagnostically accurate images every single time. This is very important for radiologists to make precise interpretations. Third is about regulatory compliance. Healthcare is a highly regulated industry for good reason. The Department of Health and the Food and Drug Administration, they regulates the use of these machines or machines emitting X-ray, and a QA program is one of their requirements. Quality assurance is a necessity. It is a shared, continuous responsibility of both medical physicists and radiologic technologists. But what quality assurance means in the context of radiology? Quality assurance or QA is a planned systematic action or set of actions. It's not something we do spontaneously. It is designed to ensure that every aspect of our service and every image we produce consistently meets the required standards for quality. The goal is very clear. So the goal of QA is to ensure consistent, high quality diagnostic images with the lowest possible radiation dose to the patient. This is where the ALARIA principle, again, comes into play. As low as reasonably achievable, every action we take in QA is ultimately aimed at protecting our patients while we provide the best possible diagnostic information. Okay, sometimes the terms quality assurance and quality control, they are used interchangeably. But what's the difference? What is QA and what is QC? So when we say quality assurance or QA, it refers to the overall system and activities that ensure quality. So let's think of it as the policies, the training programs, the design of the entire quality system. When we say quality control, on the other hand, it refers to the operational techniques and activities used to fulfill those quality requirements. These are the daily checks, specific equipment tests, the hands-on actions. So QC is a part of QA. In making a QA program, what are the key components that we need to consider? So in making a comprehensive one, so they include first and foremost, equipment and performance and calibration. Equipment performance and calibration. This is to ensure that our machines are always functioning optimally. Personal competency and ongoing training for everyone involved in imaging. Patient care and safety protocols. And finally, processes for image processing and archiving to maintain the integrity and accessibility of diagnostic information. All of these components, they work together to build a QA framework or a QA program. Okay, now let's go to the critical roles of the medical physicists and the entire quality assurance program. Okay, so what are these rules? The medical physicists, they bring a deep understanding of physics, radiation biology, and medical imaging. And the medical physicist or us, we ensure that the patient or the safety and efficacy of imaging equipment we used in our department is okay. First, acceptance testing and commissioning. So when we have a brand new X-ray machine installed in new one, such as CT scanner, mammography unit, the medical physicist, we are the ones who conducts initial testing and to ensure the equipment meets all the manufacturer specifications and regulatory requirements. After that, we commission the machine. We optimize and calibrate all the settings specifically for our clinical use. And we make sure or we ensure it performs exactly as it should. Routine quality testing or routine QC testing. After the acceptance testing and commissioning, the medical physicist, we also perform complex specialized tests on a routine basis. So sometimes it's annually, semi-annually, quarterly, and so on. Depends on the QA program. These aren't just simple checks or simple tests. These involve measurements to verify things like accuracy, linearity of radiation output, uniformity and noise levels of images, spatial resolution, precise those measurements. And this checks or this test also ensures that the machine's performance remains consistent over time. Radiation safety and shielding. The physicist, we design and verify the protective shielding for our imaging rooms. And this also ensures that both patients and staff are protected from scattered radiation. We also perform calculations to assess patient and staff radiation doses. We make sure that it's within the limit. And we are also, the medical physicists are the advisors on overall radiation protection program. So in our department, we should be the one doing radiation protection program lectures. Protocol optimization, ensuring that we get the best possible images with the lowest and necessary radiation dose for each patient. And again, regulatory compliance. These are very important and they're instrumental or the medical physicists are instrumental in ensuring that the facility or the hospital or the department adheres to all national and international radiation safety and quality standards. And lastly, education and training. The medical physicists, we play a crucial educational role, which provides training to the staffs, including radiologic technologists on radiation physics, safety protocols, and so on. Okay, what about the radiologic technologists? Because they are, or you are the front line in our imaging departments, their role is very essential in the execution of the QA program. First, daily, weekly QC checks. While the physicists or us, we perform the complex annual tests. The technologists, they are responsible for the routine or more frequent checks. This includes visually inspecting the equipment, console and the monitors. Also involves simple phantom tests as prescribed by the physicist or us mentioned in the QA program, regularly checking display monitor calibration using tests patterns. Next is on protocol selection and positioning. It means consistently selecting the correct imaging protocol for each patient and their specific clinical indication. It encompasses accurate and consistent patient positioning and knowing when and how to effectively use devices and mobilization devices if needed to ensure image clarity and patient safety. Next is image review. After every exposure, of course, the technologists, their role is to evaluate the image. Are there any artifacts, contrast appropriate? Is the anatomy properly centered and the exposure correct? Understanding all of this is what constitutes a truly diagnostic quality image, and being able to identify this is a skill. Documentation and reporting. Documentation of all QC results is very important. Reporting unusual noises, unexpected image quality issues, or patient incidents. This immediate reporting or feedback is very important to the appropriate personnel, whether it's the physicist, biomedical engineer, or supervisor. So this is very crucial for timely resolution. Patient communication and safety. The radiologic technologists have a direct patient contact. Making clear communication is important. So explaining procedures reduces patient anxiety and movement, which directly impacts image quality. Consistently applying OLARI principles through proper collimation and shielding is a daily responsibility that ensures patient safety. And lastly, continuous learning, staying updated on new technologies, best practices, and the latest radiation safety guidelines through continuous education and training ensures that our radiologic technologists remain highly competent and contribute effectively to our QA framework. So let's think about it. Working hand in hand, the synergy between the physicist and the radiologic technologist. It's neither the physicist nor the technologist can achieve optimal QA alone. Their roles, while different, are complementary and interdependent. The physicist's contribution, the what and the why. The medical physicist provides the deep scientific backbone. They're the ones who give us the calibrated tools, established regulatory framework, and provide the validation of systems performance. They tell what's the perfect looks like and why is it essential, or ensuring fundamental accuracy and safety of the equipment. The radiologic technologist, the how and the when, is they execute daily operations. They perform routine checks, observe changes in the equipment or image quality, and directly implement all safety and quality protocols with the patient. They show how to maintain the perfect and standard day in and day out. When these two roles together or come together in strong collaboration, what will happen? Okay. We see enhanced patient safety, which means fewer errors, consistently optimized radiation doses. We achieve image quality, leading to more accurate diagnosis of patients. There's efficient problem solving. Issues are easily identified and resolved quicker when both perspectives are involved. And lastly, ensure regulatory compliance, smooth inspections. Okay. So in conclusion, when medical physicists and radiologic technologists just work hand in hand, communicating effectively and sharing responsibility, we create a role, both us, the medical physicist, and you, the radiologic technologist, an environment that ensures the highest quality of care and ultimately benefiting every patient. And that's all for tonight. Thank you all for listening.
Thank you so much, Ms. Perianes, for that detailed and insightful presentation. You have clearly shown how Quality assurance is not just a checklist, but a shared philosophy that drives radiologic excellence. And also your emphasis on proactive collaboration between technologists and physicists gives us a clearer roadmap for safer, smarter imaging. We appreciate your dedication both inside the hospital, clinic, and the classroom. So now we proceed to the presentation of our second speaker, and allow me to introduce him. Our next speaker is a dynamic leader and academic whose professional journey has bridged clinical innovation, business strategy, and data science, making him a standout voice in Philippine medical physics. Mr. J. L. Inamarga is a medical physicist specializing in nuclear medicine and currently serves as the vice president of the Society of Medical Physicists in the Republic of the Philippines. His influence spans across consultancy, teaching, and organizational leadership. He obtained his BS, Bachelor of Science in Physics, with a specialization in medical instrumentation from De La Salle University. In 2014, he completed his master's in applied physics, medical physics at the University of Santo Tomas in 2018, followed by an MBA from the Ateneo Graduate School of Business, where he was recognized with the prestigious gold medal for academic excellence. Presently, he is pursuing a Master of Science in Data Science at the Asian Institute of Management. Mr. Inamarga has served as a medical physicist at Makati Medical Center from 2018 to present, and now works as a consultant for nuclear medicine facilities within and beyond Metro Manila. He also lectures part-time at De La Salle University, Manila, where he fuses theoretical rigor with clinical experience. But beyond science, he lives a life of purpose and balance, embracing the outdoors as a mountaineer with a personal mission to reach the 7 summits of the world. His presentation today is Radiation Safety and Dose Optimization, a Shared Responsibility. We'll highlight collaborative frameworks that empower technologists and physicists to co-own patient protection and protocol optimization. Let's warmly welcome Mr. J. Inamarga.
Good evening, everyone. I am Jay Inamarga, and I'm here to briefly talk about radiation safety and dose optimization, a shared responsibility. As with all my other speaking engagements, be it in person or online, I will begin this one as well with gratitude. Gratitude to the individuals and organizations who made this event possible. Thank you so much for having me. For the conflict of interest, I have nothing to declare. And as shown on your screen, this will be the outline of my presentation for tonight. So we have the objectives, the principles of radiation protection, a brief discussion only regarding the topic of optimization and the importance of having shared responsibility, and some final words and references. For the objectives, I use the words revisit and reintroduce simply because we know for a fact that these are not new pieces of information for us. It's actually more of a reminder why having a shared responsibility within our institution is in the best interests of all our stakeholders. And of course, I'd like you to take a step back and do some bit of reflection in terms of your institution's culture. No? Is it a good does the institution have a good radiation safety culture, or do you think there are points that we can improve on? No? And before that, I'd like to ask these 2 questions. Does culture come first or does it come last? And the other one is more of a hypothetical question. No? If you were the manager of a unit or department and an accident involving a patient happens, will you inform the higher ups and the patient, or will you cover it up? So let's try to answer these 2 questions towards the end of the presentation. No? And let's also take a minute to appreciate this cartoon wherein one person asks, which button do I push? And the other person says, usually just punch them both. And if we look closely at the labels of the buttons, we see there detect cancer and cause. And on the right side, we see cause cancer, right? Now, we won't go into the nitty-gritty of the effects of radiation due to time constraints, and we'll head straight to
Oh yeah.
principles of radiation protection.
Sorry,
This will also just be a brief one, since we all know that the
नहीं करो
basis
ये
for all
पहचाने दो
radiation
सब लोग
protection
मॉल रूम में
activities is
बिठा कर
that
रखे सीटी में बिठा कर रखे
radiation is
जैप में बिठा कर
harmful,
रखे
and that the smaller the radiation doses we receive,
हाँ बुला सकते हैं अभी वो
the
एक बार
smaller
चेक
are
कर
the
दूंगा
risks,
फाइनल
right?
एक बार
So we
एडिशन ऑन
always
करके उसी में
operate
ऑन
under the
करा था
premise that radiation is harmful, so we need to keep the doses really, really low as much as we can without compromising the intended or like
वेटिंग
the
में नहीं है कोई
intended diagnostic information that we would want to obtain from the scan, or without compromising
ललित
the
से पूछ लो भैया
therapeutic
क्या हो
effect
गई इसे
of
मैंने कराना है ना बात
radiation,
करो
right? So these are the three principles of radiation protection. We have justification wherein it's in simple terms, the benefits should outweigh the risks. Optimization, we'll discuss that later, and those limits. So again, we don't really have the time to discuss these three in detail one by one. But if there's one thing I'd like to highlight, it's this. I would want to highlight this distinction between the three simply because I've seen some instances wherein even the most experienced technical person is having a hard time explaining this to the management. Does the three principles of radiation protection apply to everyone, or does it just apply to the patients? So which is which, no? So the first two, justification and optimization, it applies to patients, and the last one, those limits, it applies to radiation workers only. So please remember that and do your best um, to review about these concepts now, because as radiation workers we should know this by heart. Yeah. And on the topic of optimization, what does optimization state? So according to the optimization principle, it states that the likelihood of incurring exposures, the number of people, and the magnitude of their individual doses should all be kept as low as reasonably achievable. So this is the famous acronym ALARA. And continuing the definition, it says here, taking into account economic and societal factors. Would you believe most people forget to mention the last part of this definition? They always, I mean, more often than not, they tend to forget adding adding the words taking into account economic and societal factors, which I hope we don't forget, no? And I just like to have a quick example, just just so that for the sake of discussion, no? This image shows a sample workflow in nuclear medicine. So thank you to the IAEA Human Health Series number 33, entitled Quality Management Audits in Nuclear Medicine Practices. It's a good reference if you're trying to establish an audit system for your nuclear medicine facility, and it's free, so you can readily download. You can readily download it from the internet. No? So as shown here, there are a number of processes involved in a nuclear medicine facility. So you have the management processes, you have the primary processes, and you also have the support processes. No? So if someone asks, where does the optimization principle come, where does it come in? No? And I did ask a few of my colleagues before, and they specifically narrowed it down to these two steps: the image acquisition and the therapy. No, but yeah, simply because they justified it that this is where you choose the appropriate exposure factors, where you do the weight adjusted computation of the dose before you administer it to the patient, and so on and so forth. So yeah, in essence, they're correct. Wherein the optimization principle applies in this specific aspect of the primary processes, but it can be better, no? So most individuals forget that the optimization principle also entails economic and societal factors. That's why if you're going to ask me where does the optimization principle apply, in this nuclear medicine workflow, my answer would be it should apply to the whole process, no, not just specific steps within the process, um, as shown here in the image, no. So again, just to highlight this further, optimization or like the whole nuclear medicine process alone, for the sake of discussion, or just for this example alone, it's a complex one. So this also explains why optimization should be applied to the whole image, the whole process, involving even the management and even the support processes. So not just towards the primary processes, no, because a lot of things could go wrong if you don't focus, or like if you don't take into account how the other processes affect the primary processes. So that's what I'm driving at. So I hope I'm making that clear. So if you're going to apply the optimization principle, don't just apply it to the imaging or to the therapeutic procedure, but please apply it to the whole process, no? So from the start, wherein the patient is being interviewed, where the patient is being scheduled, and so on and so forth, no? And on the topic of shared responsibility, I did a quick Google search about the definition of shared responsibility. And according to Google's Gemini, the AI product of Google, so a shared responsibility means that multiple parties are accountable for a task, outcome, or goal, with each party contributing to the overall effort. It's not about the one individual or entity bearing the full burden, but rather a collaborative approach where everyone involved plays a part. And I'd like everyone to pay attention to the last sentence. And again, I just like to read it. Yeah. It's not about one individual or entity bearing the full burden, but rather a collaborative approach where everyone involved plays a part. And if you ask me, whose responsibility is it anyway to implement radiation safety, to make sure that the radiation protection and safety program is always updated, is always implemented, and if there are things that need to be revised, then someone will take care of it, no? So if you're going to ask me, whose responsibility is it anyway? Is it the RPO alone, or the radiation protection officer, or is it the radiologic technologists, or is it the medical physicists? Is it the responsibility of the nurses, the receptionists, or is it even the responsibility of the management alone? The short answer is it's actually everyone's responsibility. No? Gone are the days wherein we put the burden of implementing the contents of the radiation protection and safety program to the designated radiation protection officer. No? So we have to take a proactive stance in ensuring that all radiation workers, not just the technologists, not just the physicians, not just the medical physicists, are aware of their responsibility as far as radiation safety is concerned. Why? No? You might ask, why can't we just let the RPO handle it and have us focus on our technical duties? No? I've actually listed down a number of things why it's important for us to be active, to have the initiative, to participate in the development and implementation and monitoring of the radiation safety procedures in our institution. No? I'll probably just give 3 or 4 in the interest of time. No? So number 1 is that while procedures and steps are in place to minimize the risk of errors, it can still happen despite best intentions. So number 1, that's it. So no matter how foolproof you think your procedures or your protocols are, there is still a chance that something bad might happen despite best intentions. And number 2 is that medical errors happen more often than you think. Errors involving radiation happen more often than you think. No, so there are a number of documented cases all over the world, and if you have the time, please feel free to review it, and you might be surprised with the root cause of why those incidents happen. No. Number three is that if and when things like this happen, it's best for us to document and report them so that there will be an opportunity to learn. No? So imagine if you were consider like you were a witness to an incident and you chose not to report it simply because you think it's not your responsibility to report it. No, so there is a chance for us, or actually that's already an opportunity to learn lost because of you said, oh, that's not my responsibility, when in fact it should be our responsibility. No, and number four, lastly, just four reasons now. It also encourages us to look at the process first, no, before looking at the human factor, in case incidents like this happen, no. So if there is a shared responsibility within us, we can also direct our attention to how the processes are formed, and there we can do some corrective actions or corrective procedures in order for us to prevent the a similar instance of an incident happening. No, so yeah. And moving on to answer the two questions earlier, does culture come first or does it come last? And the second question, again, if you were the manager of a unit or department and an accident involving a patient happens within your unit or department, will you inform them? Will you inform the higher ups or the patient, or will you cover it up? No. The answer is for the first one, culture comes last always. No. So culture in layman's terms, it's how we do things around here, how we get the job done, how we treat another, how we work together. No. And if you're looking for the proper definition or like textbook definition of culture, according to Gerd Hofstede, it's the collective programming of the mind which distinguish the members of one group from another. That's why if you're about to transfer to another job, sometimes more often than not, you would ask, "How's the culture there?" No? So instinctively, we're also looking at how things are being done there. No. So I'm about I think this is the second to the last slide. So final words in terms of when we're dealing with radiation safety and dose optimization, and we're talking about shared responsibility. I think the best way to develop to develop to improve or to develop that culture of shared responsibility is to instill a sense of ownership amongst the stakeholders, amongst the people involved in that institution. No? Because instilling a sense of ownership can greatly contribute to the improvement of a good radiation safety culture within your institution. What do I mean when I said sense of ownership? It means that when someone has made I don't know, let's just say for the sake of discussion, an emotional investment in making a document or a protocol involving the radiation safety practices in an institution, there's this sense of ownership. No? So it's easier for that person to uh, to practice what's written in the document that he or she drafted, simply because he or she is the part or he or she contributed in the development of that document. No, so what I'm trying to say is it's like you're getting the buy-in of these people so that they could also be more proactive in um, promoting the in promoting radiation safety, and uh, in promoting radiation safety, as well as encouraging shared responsibility within the stakeholders, because again, no man is an island, and it's much easier for everyone if everyone will do if all the stakeholders, if all the radiation workers will do their job uh, in promoting good radiation protection practices. So I think that's it for me. And yeah, thank you so much. So if you have questions or clarifications, please feel free to email me. And once again, thank you to Ms. Pichi Luna and to Mr. Ramon Carlo Prospero, as well as the two organizations shown earlier, for this wonderful event. So these are the references. Thank you.
Thank you, Mr. Inamarga, for that dynamic and thought-provoking discussion. Your expertise in nuclear medicine and your passion for innovation, data, and safety came through powerfully. The strategies you shared truly reinforce the idea that dose optimization is not a technical choice, it's also an ethical responsibility, and it's inspiring to hear how our profession can balance advancement with accountability. So moving now, let me introduce to you our third and last speaker. He is Mr. Ramon Carlo Cruz-Pero. Our third final speaker exemplifies the impact that passionate leadership and deep clinical knowledge can bring to a profession. Mr. Ramon Carlo Cruz-Pero, the president of the Society of Medical Physicists in the Republic of the Philippines, currently serves as the Health Physicist 3 at the Department of Radiology, University of the Philippines General Hospital, with clinical focus in nuclear medicine and cross-specialty expertise in diagnostic and therapeutic radiology. He earned his academic degrees from the University of the Philippines, Manila, and De La Salle University, Manila, and now teaches at both universities as a senior lecturer 1 at UP Manila and professional lecturer 1 at the De La Salle University. He has been central to developing the Philippines' first graduate programs in medical physics, building stronger foundations for future professionals. Mr. Cruz-Pero has played key clinical and regulatory roles, notably helping establish the country's only government-owned operational PET-CT facility. He is also among the only 2 trained medical physicists supporting MR-guided focused ultrasound surgery for Parkinson's disease in the country. In oncology and diagnostic imaging, he leads quality assurance programs that combine technical depth with a patient-centered impact. His leadership extends well beyond the clinic. He served as public relations officer of SMRP from 2020 to 2022, vice president and head of the Regulatory Affairs Committee until 2024, and has led several national conferences, including the Philippine Conference on Medical Physics for 4 consecutive years. In recognition of his contributions, he has received the CFOMT Young Leaders Award, the SMR-PRP Distinguished Service Award, and most recently, the Garbo sa Toledo Award 2025 from his hometown in Cebu. Tonight, he will deliver a presentation that not only explores scientific advancements, but also addresses structural collaboration in our field, breaking barriers in diagnostic imaging, the role of medical physicists. Let us welcome President Cruz-Pero.
Good day. I am Ramon Carlo L. Cruz-Pero, a medical physicist. Today, I'd like to share how we are helping make diagnostic imaging more accurate and safer. The goal of this talk is simple: to show how collaboration between medical physicists and radiologic technologists lead to better diagnostic imaging. We'll explore our distinct roles, our shared goals, and the power of teamwork in delivering patient-centered care. Diagnostic imaging saves lives. Whether in trauma care or cancer staging, it allows clinicians to see inside the body without surgery. But achieving a clear, accurate, and safe image requires a coordinated effort from radiologic technologists, radiologists, medical physicists, and engineers. From the physicist's perspective, a good diagnostic image isn't just textbook perfect. It's one that provides enough clinical detail for diagnosis while keeping radiation doses low and equipment within standards. So how do we consistently achieve that balance? It starts with shared responsibilities between physicists and technologists working as one team. So what do physicists do? As per the IAEA TCS 47, medical physicists play a vital role in ensuring the safety, accuracy, and consistency of diagnostic imaging. One of their core responsibilities is the implementation of structured quality assurance programs. These programs are designed to routinely assess, radiographic equipment, and monitor image quality, allowing for the early detection of performance issues that could affect diagnostic accuracy. Also, medical physicists closely work with technologists and radiologists to optimize imaging protocols. By applying physics principles and the ALARA principle, they help fine-tune exposure parameters to strike the right balance between image clarity and radiation safety. Another crucial responsibility of medical physicists involves performance testing and calibration of imaging equipment. We conduct acceptance testing, periodic calibrations, and constancy checks to ensure that systems meet both manufacturer specifications and regulatory standards. Beyond equipment and protocols, medical physicists also serve as educators. They train on fundamentals of imaging physics, quality indicators, and proper use of exposure parameters. This training includes providing feedback to improve image acquisition and helping technologists avoid common pitfalls such as artifacts or inappropriate exposure settings. Then, what do radiologic technologists do? As per the IAEA TCS 25, radiologic technologists are on the front lines of patient care and image acquisition. They are responsible for proper patient positioning and selection of the appropriate imaging views based on clinical indications. Their ability to achieve the correct projection and minimize patient motion is critical to obtaining diagnostic quality images. In addition to positioning, radiologic technologists also manage real-time selection and adjustment of exposure parameters. Depending on the patient size and exam type, they fine-tune KVP, MAS, and other technical settings to ensure ideal contrast and image density while keeping radiation dose to a minimum. Radiologic technologists also perform daily equipment checks to ensure that all imaging systems, including the X-ray tube, detector, and console, are functioning properly before each use. If they encounter any malfunctions or image artifacts, they are responsible for reporting them promptly to prevent unnecessary repeat exposures. Furthermore, radiologic technologists are the primary professionals who interact with patients during imaging procedures. They play a key role in patient communication and preparation by clearly explaining the exam to patients to reduce anxiety and movement, and by ensuring the removal of objects such as jewelry or obstructive clothing that can cause artifacts. These tasks contribute to the production of clear, high-quality diagnostic imaging. The roles of medical physicists and radiologic technologists frequently interact, particularly in areas critical to the quality and safety of diagnostic imaging. These overlapping responsibilities can sometimes become sources of tension if roles are not clearly understood or coordinated. One key area is quality assurance. Medical physicists are primarily responsible for developing comprehensive QA programs, such as establishing the framework, defining performance metrics, and ensuring regulatory compliance. Radiologic technologists, on the other hand, play a vital role in implementing these protocols in daily clinical practice. When collaboration is strong, their partnership ensures that imaging systems operate consistently at high standards, ultimately resulting in reliable, high-quality diagnostic images for patient care. Another significant area is in the optimization of imaging protocols. Physicists apply their knowledge on radiation physics to design protocols that minimize dose while maintaining image quality, and radiologic technologists are responsible for applying these protocols in real time during patient exams. They make on-the-spot adjustments to exposure settings based on clinical needs, patient size, or movement, making protocol optimization a truly dynamic shared process. Equipment performance is also a shared responsibility. Physicists perform detailed acceptance testing, calibrations, and periodic evaluations of imaging systems to ensure everything functions within regulatory and manufacturer standards. Technologists, meanwhile, monitor daily performance, performing pre-use checks and promptly reporting any issues. This continuous feedback loop between physicists and technologists helps maintain safe, functional, and diagnostically accurate equipment at all times. To address and prevent such conflicts, effective communication is one of the most powerful tools in diagnostic imaging. Also, collaboration between medical physicists and radiologic technologists is essential to achieving the highest quality of care we can offer our patients, which is our main goal of our work in this field. True collaboration goes beyond simply working side by side. It involves active listening, open feedback, and a shared understanding of the concepts such as radiation dose, patient positioning, and imaging artifacts. By engaging in joint QA sessions and valuing each other's expertise, we foster mutual respect, build trust, and ultimately enhance both image quality and patient outcomes. Excellence in diagnostic imaging is never a solo act. It's a result of partnership between physicists who ensure accuracy and safety and technologists who translate those standards into practice. Together, we build science and patient care in delivering sharper, safer, and more effective images, one scan at a time. To close my lecture, I warmly welcome you to next year's Southeast Asian Congress of Medical Physics hosted here in the Philippines. This event gathers experts across Southeast Asia, and for the first time, we are opening our doors to our close allies in imaging, you, our radiologic technologist colleagues. Let's continue this journey together. Thank you.
Thank you very much, Mr. Cruz Vero, the president of the Society of Medical Physics of the Republic of the Philippines. Your presentation was a call to action, reminding us that medical physicists are not working behind the scenes, but in partnership with radiologic technologists to shape diagnostic breakthroughs. From training future professionals to advocating for access and equity, your leadership clearly breaks barriers in every sense. We are grateful for your vision and dedication. And again, thank you so much to our distinguished speakers for those enriching and forward-thinking presentations. Each of you has truly deepened our understanding of the evolving partnership between radiologic technologists and medical physicists and the vital role we play in advancing safe and high-quality care. So at this time, we are pleased to have a transition now from the discussion to the Q&A session. We now invite our speakers back to the screen, Ms. Vanessa Francesca Perianes, Vice President Mr. J. Inamarga, and the President Mr. Ramon Carlo Cruz Vero. We also extend a warm welcome to our participating presidents of Radiologic Technology Societies as panelists and our invited panelists, institutional representatives who may wish to offer reflections or ask questions or share brief remarks in response to today's presentations. While to our audience, you may send your questions via the Zoom chat or use the raise hand feature to key in your questions. Kindly state your name and, if applicable, indicate which speaker your question is addressed to. So let's make the most of this opportunity to exchange insights and engage with our experts here as we move forward together under the banner of precision, protection, and progress. All right, so any panelists who would like to give reflections or reactions before I proceed with the questions that we have gathered here for our speakers. All right, so while I am waiting, so I'd like to address a question here. A first question to Mr. Ramon Cruzpero. Sir Ramon, a question here goes, I would like to read it exactly. How can we, the radiologic technologists and medical physicists, build a stronger feedback loop, especially when it comes to equipment performance and image quality issues?
Hello, good evening, everyone. So, once again, thank you for inviting us. On behalf of the Society of Medical Physicists in the Republic of the Philippines, thank you, PART, Philippine Association of Radiologic Technologists, as well as all other radiologic technologist organizations from the different countries. Now, to answer your question, it starts with open communication. Now, I will base it on my experience in PGH, where I'm actually affiliated as the medical physicist to the three areas: diagnostic radiology, radiation therapy, as well as in nuclear medicine. So, an open communication actually leads us to a good response on how we're going to actually resolve problems that are actually occurring real time. So an example of that one is if we have issues with a machine, our radiologic technologies promptly actually inform us. Though this is not our work to fix the machine, because that's actually the work of a biomedical engineer. But in a way, we are actually the bridge of the technology as well as the theory behind that machine also. So in a way, we can actually probe, and at the same time, we can actually do basic troubleshooting already. And of course, we're going to actually report that one to our biomed technicians or engineers already. In that example, we can already say that there's if we are actually having this type of communication, that there are no barriers between radiologic technologies as well as medical physicists, we can actually run smoothly. And at the same time, our aim here is actually to create a good diagnostic imaging. So getting an excellent diagnostic imaging should not just be our standard. In our profession, it should be our way of life as professionals in imaging already. I think that's it.
Maybe this is a follow-up question. So, dear sir, you are affiliated with a government and a private institution, am I right?
Yes.
So, do you find some similar or differences or similarities with regards to what you said a while ago?
Yes. I can say, as mentioned, I'm also affiliated with private hospitals as consultant, and at the same time, I'm affiliated with government hospitals. So I can say, in terms of the breed of radiologic technologies that we have in the Philippines, we have actually a good quality of radiologic technologies. I never had issues with dealing or with communicating with our radiologic technologists. In terms of bureaucratic processes, that's where actually the government agencies will actually be, let's say, it will lag behind compared to our private institutions. But other than that, in terms of support, I can say that both government as well as private institutions where I am affiliated, they're actually very supportive of providing the good quality that we can actually provide to our patients.
Thank you for that answer, Sir Cruzpero. All right, so next question here is for Sir Jay. So the question reads as follows. So is there an approach or technique that you can recommend where shared responsibility and dose optimization will flourish in an organization?
Okay, thank you, Ms. Peachy. And of course, once again, I'd like to congratulate the organizers of this event and at the same time for the invitation that you sent us. Truly a remarkable evening. And to answer the question, of course, thank you again for that question. There was a time wherein I thought that change happens from top to bottom, meaning the instructions coming from the CEO down to the let's say chief operating officer, then to the senior managers, and then to the employees was the only way to go. No? And while that may work for some institutions, I'd like to share with you one method that worked with us when we were putting up our PET CT facility in my previous institution. No? Oh, by the way, I'm no longer affiliated with Makati Med. So yeah, just to correct that one. We tried the grassroots approach wherein instead of the instructions coming from, or like the decisions, or like the instructions coming from top to bottom, it's going to be bottom to top. So this one worked for us simply because we're the technical people. We know what we're doing, and instead of, sometimes we do antagonize, or like in generals, there are cases wherein we antagonize the management simply because they're not technical people, but they're more of a number or business people. But that's actually not the way to go. Wherein if there's a chance for you to educate them with the things that we are doing, I think that's the way that you should do it. No. So in our case, what we did was it was a bottom to top approach when initiating change and when establishing a culture of safety within our center. No. So it's driven by collective action of actually the technical people, the ordinary people, the front lines. No. And then that's what we show to the management, and that's where the understanding comes in, and that's where the communication begins to flow continuously and uninterruptedly. So I think most people should give the grassroots approach a chance. And also, this is of course it might take some time, but definitely if you do it right, then there will be countless benefits for your patients and all the other stakeholders. I think that's it. Thank you, Ms. Peachy.
Thank you so much for that very good suggestion and options, Sir Inamarga. I have here another question for you. This goes with more facilities digitizing their imaging workflows, how do we ensure that those optimization and radiation safety remain a priority?
Oh, that's a good question, Ms. Peachy. I was just thinking about it earlier because we had that discussion in our class, and I think it all boils down. Here's what I think. No, I think it all boils down to one word: culture. So even if you shift from your current workflow to digitizing your workflow, if the culture of safety is strongly embedded within the people in your institution, I think there won't be any problem, because at the end of the day, the um, it should be noted that the digitization of the imaging workflow, it aims to ensure a faster and more reliable radiology service. No? But it does not give the workforce a free pass to become relaxed when it comes to doing their jobs. No? It's there to optimize everything, but like what I said earlier, you just don't look at the one process, one aspect, like the imaging acquisition or the therapy part, but you also have to look at the whole workflow. Okay, so it all boils down to culture. So if you have a good foundation of good radiation protection practices, and your culture is like really solid, really founded on a good principles and like good morals, then I think there won't be any problem. But just the same, I'd like to end my answer with if there are any instances wherein the digitization backfires or like some incidents happen, please try to use that as a learning lesson, and do not try to cover it up. And yeah, I think that's it.
Yes, thank you so much, Sir Inamarga, for that. Again, a very good insight from you answering that very interesting question. I also have another question for President Cruz Pero. This is from our chat. Here it says, from your shared developments in diagnostic imaging, what in the underserved areas where medical physics may not be readily available, how can technologists fill in gaps without compromising safety?
Thank you. It's true to all. Almost all countries wherein we actually have, I guess, except the America or the US. But in most countries, we actually have scarcity of medical physicists. In the case of the Southeast Asia, I can actually say that we also have the scarcity of medical physicists. Also here in the that's also true in the Philippines also. So going back to our role as educators as well, it's not only educating allied professional help that can actually help us with um, with um, making sure that we have a quality, or we will be able to give the quality of service, which is actually a good or an optimal diagnostic image. So with this one, continued training, joint QA sessions. I understand that we had actually a number of workshops already in the Philippines wherein you were inviting actually medical physicists to learn about QA, QC test in CT scan as well as an MRI. So I'm actually hoping that we'll have a more collaborative and at the same time stronger ties in terms of doing this workshop. I'm really hoping that we can actually continue this one, and we can actually do this one in a bigger scale, such that we will be learning from one another. So there are actually some radiologic technologies that are actually very, let's just say, more advanced than a medical physicist. Let's just say in Thailand, their medical physicists are also radiologic technologists, and in terms of knowledge as well as practical skills, I can say that they are actually at par with a purely medical physicist. So with this one, there is already there are actually medical physicists wherein they're already wearing two hats. Now here in the Philippines, we don't have that case. There are only few radiologic technologists who are actually pursuing medical physicists, and before they can actually pursue medical physicists, they have to undergo credit courses so that they will be able to meet the requirements for the math and the physics part. And I'm really grateful that they pursued medical physics also, and they've seen that the dynamics as well as the pedagogy of medical physics is actually quite different from a radiologic technology program. So with this one, the best answer for now, especially for the hospitals or for institutions without medical physicists, I highly suggest that if there are actually workshops wherein there are medical physicists and radiologic technologists who are actually aiming to learn in making up or in establishing a QA program, or perhaps learn QC tests, I highly suggest that they are going to join and participate in one way or another. They will learn a thing or two there. Now, it's not just there. There's also a possibility that you can actually learn it overnight or just a number of days. So the other alternative is actually to do, if there is telemedicine, why not do telehealth of QA? If you have already a medical physicist as a friend, you can always ask help. I mean, we are actually just a one call away if you need help, and we're not that type of people wherein we're too high of ourselves to think that we should be this and that, or we should be the only people who should do the QC test or the QA, the QC or the QC test of machines. We're actually trying to actually let others learn what we are also learning in our program. So this is where also I go back to the first part about open communication. It's not only resolving problems, but it's actually to actually learn and unlearn what are the things needed, that my profession as a medical physicist needs support from you as radiologic technologists. And at the same time, we will be, or may perhaps we can actually support you in one way or another in terms of what is lacking or needed in your institutions already.
I saw Miss Vanessa trying to connect with us. We have here a question for her, but while we are waiting for her to reconnect, I saw the hand of, yes, President Vimalasena Vitarana of Sri Lanka. Would you like to share something, or you have a question?
Yes. Thank you, Pichi. this is not a question anyway. The any of the three lecturers can answer this. Do you hear me? Okay. So now in Sri Lanka, there is a medical physics postgraduate program in one of our universities. So up to the last year, the radiological technologist who has graduated from the universities can join that could join that program to follow and become a medical physicist after the following the course. But unfortunately, our medical physicist, their trade union, has objected to this. They say that the radiographers or the radiology technologists doesn't have much physics knowledge to follow this program. But in fact, we follow the radiographers or the radio technologists. They learn physics in the universities and all the physics related to the medical imaging and radiotherapy program. They have done all the physics terms. So why? And I just want to know what is your idea? What is your opinion regarding this? Is it correct or wrong? What are their opinions? What do they say regarding this? How can you comment on this?
Jay, would you like to answer, or I would
Yeah,
answer?
anybody can
Yeah.
answer, yes.
PRC, I believe as the president, you can take this one. Although I can add a few notes later, just in case something comes up. But yeah, please feel free to answer.
Thank you. Now, even us medical physicists, after we graduate in our program, we actually have still a residency and certification process. So we're not we don't rely on what we have learned only in the graduate school. So this residency program focuses on the clinical aspect of a medical physicist specializing in diagnostic, radiation oncology, as well as in nuclear medicine. Though in our country, we're still trying to establish the nuclear medicine, medical physics residency and certification exam, and hopefully radiation certification process, which we hope that we can already start this up next year. Now, with regards to your answer, with radiologic technologists, the conflict, still retraining will be the best option. It's not well, it's human nature to be offended if we are being rejected, but there are actually reasons as to the reason. There are actually reasons that we don't see right now as to the reason why there was there was rejection. So I would take it humbly, based on their recommendations as to what I lack as a radiologic technologist to proceed as a medical physicist, so that I can actually do what a medical physicist should do in an institution. So I don't see, I know this will be a hard or a challenging one. In Sri Lanka, I am sure there are only few medical physicists also there. Am I right, sir?
Yeah, there are medical physicists, but some of them they are appointed for in the government.
Yeah.
Just the people with physics degree are appointed as medical physicists. After that, only they follow the medical physics program. So
Yeah.
that is the problem. So they.
With that, we actually have an IAEA TCS 56 that would actually delineate or summarize, or let's say summarize in detail the program of what should a medical physicist should have. So most of the medical physics program in across the globe is actually following that IAEA TCS 56 on establishing a medical physics program. So I suggest that the medical physics program in Sri Lanka, if there's one, They have to review if they're actually following the necessary knowledge and skills that should be required or that should be learned by a medical physicist that will actually guide them. This was also one of our issues recently in one of our medical physics graduate institutions, wherein it's loosely not following the IATCS 56, but we walk them through as to what are the needed um, courses that the program should have. And with those courses, the medical physics graduates should be equipped already after they completed the course already. So again, after they completed the course, I highly suggest that they need to have a residency and certification exam. So if there are only few members of the medical physics community in Sri Lanka, there is actually an international medical physics certification, the ICMPB. That's actually the International Committee of Medical Physics Board, or International Certification of Medical Physics Board. They can actually take that one, because that would actually check if they have actually one way of checking if they have learned something in their graduate program, in their medical physics graduate program. And at the same time, they will learn the necessary clinical skills that a medical physics should have.
Yeah, okay. Thank you. Thank you.
Thank you.
Thank you, President Cruz. Do you have any more to add, Sir Inamarga?
No, I think Mr. Prospero perfectly captured the essence of his answers. So yeah, I think I'll just leave it at that in the interest of time. I think we only have 10 minutes. So yeah, thank you,
Yes,
PRC.
yes.
Thank you, Mr.
So, yes, but let's give some quick more time to President of HKRA, Mr. Nan Tat Ming. He just raised his hand. Is this a reflection, reaction, or a question to our speaker?
Okay, thank you, Vijay. I have some questions. Okay, three presenters very good today, and may I have a questions? The first question is is there any more radiation dose monitor program or software used in the Philippines to help the medical physicists or radiographers to monitor the patient dose, and then they can maximize the protocols for the patient in the ALARA, okay, the principle. The second question is the how often of the medical physicists to do the QA for each equipment annually every year, once or two times or three times every year for the QA program. Thank you.
Okay, that's actually two good questions. First, we do have an agency wherein we subscribe for the personal dosimeters. So this is actually required by our regulatory agency that each radiation healthcare worker should have a badge or a dosimeter. Now, our regulatory agency right now is actually trying to come up with a one-time stop shop, wherein if you are actually a radiation healthcare worker from this hospital, and then later on you're going to transfer to another hospital, you can actually get the cumulative dose already. Though this is still in a beta testing, but we are actually hoping that this will actually be fully implemented already, so that wherever we actually transfer affiliations with any radiation facility, we can actually trace back our doses or the dose exposure that we have. So this is actually a long shot for now here in the Philippines. Another one is actually for patients. This has been discussed. I'm sure it is also discussed in your conferences about the diagnostic reference level. We're trying to establish that one also here in the Philippines, but we actually got feedback from other countries who have already established a national DRL that perhaps the best way for us, especially for us new or trying to establish first this national DRL, we have to fortify first our local DRLs in our respective hospitals before coming up with any national DRL. Now, as to your second question regarding the frequency of QA, as per regulations, we do annually review our QA. It's just so happened that here in the Philippines that um, I must admit that medical physicists, we were able to join the healthcare industry in the later years compared to the radiologic technologists. That's the reason also, in the Philippines, they were able to become professionals in 1993 or 1994, while the first medical physicist in the Philippines was actually in radiation oncology, but in diagnostic radiology, they were able to join sometime in the early 2000s. So that's actually more than 5 years gap. So technically speaking, if we are to ask who's doing the QA program prior to the entry of medical physicists and who's doing the radiation protection duties at the time, so that's where that's where the the conflict of the medical physics and the radiologic technologies here in the Philippines, because for the longest time, for more than 6 years or so, they have been the RPO, they have been the ones who are doing the QA/QC test. So there's this it's human nature to actually be very if there are new people, we're that let's just say we're being territorial already. This is what our work right now. Why is it that with this entry they're already taking this job, so on and so forth. But the goal here is not actually taking one's job. It's actually sharing, as mentioned by Jay's um, talk earlier. It's a shared responsibility. So prior to the entry of the medical physicist, we have the radiologic technologies as our partners. It's just so happened that we were not there yet because most of the medical physicists at the time were actually in our regulatory agencies.
Yeah, sir.
And yes.
Yes. Thank you for that question. But I'd like to give the floor, the screen now to Sir Joel Inamarga and Ma'am Vanessa, who's here now.
Okay,
Yes.
good. Thank
Yeah.
you.
Yes, po?
Yeah. Vanessa, if you don't mind, I'll go ahead. Just real quick.
Okay.
Yeah. Regarding the second question about the frequency of testing, we have to admit that there are challenges when it comes to how often we should do it because at the end of the day, since there's a scarcity of medical physicists, this isn't a problem unique to the Philippines alone. By the way, I've had some colleagues outside of Southeast Asia who have shared the same sentiments. But there are times wherein we don't normally get to follow the periodic testing simply because once the machine is in operations, especially for private hospitals here in the Philippines, the management will frown when they hear that you need to take 3 days, 3 consecutive days for you to perform the testing. So they will always ask, Jay, it's working perfectly. Why do you need to test it? The doctors are not complaining about the image quality. Why do you need to test it? Meaning everything's okay. So you don't need a reason for you to you don't need the 3 days to do this test. So I think there's the disconnect between the management and the roles of the medical physicists and the radiologic technologists. So I think we could have a separate discussion about this, but normally that's one of the things that we would like to emphasize, that while we want or while we need to do the tests, there are times wherein there are some hindrances that prevent us from doing so. That's why we have to render overtime just to squeeze it in. Like we're in after office hours. That's when we can do the test. But since we don't have the luxury of time, we normally do the tests in batches instead of doing it like in full scale testing. So I think that's one of the challenges. And Vanessa, the floor is yours if you would like to add something else. Thank you.
Thank you, Jay. Okay. Okay. I would like to add something to the answers of Mr. Jay Namarga and Sir RC. With regards to patient doses. So I am also affiliated before with one of the regulatory bodies here in the Philippines, and before we are in the process of doing this national diagnostic reference levels, as mentioned by Sir RC earlier, and before we have already started establishing, and then we decided to do it by phase. So we started with high risk
machines, which is cardiac catheterization, and then followed by computed tomography, mammography, and so on. So that's one way also of ensuring that we are practicing optimization and Alaria principle. And in our hospital, so the hospital where I am affiliated at right now, which is the Medical City, we are also planning to establish local DRLs in our hospital, and we also plan to do it by phase. So we're going to start with cardiac catheterization and so on. And for the second question, which is about how frequent is the QA is done. In my department, which is currently what we're doing is we just have established our QA/QC program wherein we decided or we put there the frequency of the different tests that we have that we need to do for each modality. And the guidelines that we use are the IAEA and so on. And also we base it with the regulatory standards. And that's it. Thank you.
All right, so I see no hands anymore being raised from our dear panelists and our society presidents. So I guess I shall proceed with the closing session. Again, thank you, dear society presidents and our panelists, to our dear three excellent speakers from the Philippine Association of Radiologic Technologists and the Society of Medical Physicists in the Republic of the Philippines, who recently gave us very insightful presentations and sparkled our Q&A. Thank you again, Ms. Maria Vanessa Francesca P. Perianes, Vice President Mr. J. Inamarga, and to President Mr. Ramon Carlo L. Cruz. Pero we have learned so much from your interesting and important discussions and valuable insights. I think we need to have part 2 of this. And again, thank you for sharing us your views about interconnected roles of medical physicists and radiologic technologists in ensuring safe, accurate, and high-quality diagnostic imaging. We hope to hear more from you next time. Now, before we officially close today's session, we are excited to share a glimpse of what's coming next. Our upcoming CPD Asia program for July will be hosted by the Taiwan Society of Radiological Technologists, TWSRT. And to give us a warm invitation and a preview of the next session, may we now call on our esteemed colleagues from TWSRT to share a few words. I think that's from President Wu Yuan.
Hello, Petri. Can you share the post of our?
Yes, IT team, can you please help me share the poster from TWSRT?
Okay, I'm the president of TWSRT, and TWSRT will host the upcoming Asia CPD conference on July 30. We are honored to have 2 speakers. They are both the professors and also the editors in chief for our journal. Professor, should I wait for the post? Okay. And the first Professor Jia Feng Lu from National Yangming Jiao Tong University in Taiwan, specialized in MRI, artificial intelligence, machine learning, and bilingual education. He will share. Okay, the first speaker is Professor Jia Feng Lu from National Yangming Jiao Tong University. His specialty is MRI, artificial intelligence, machine learning, and bilingual education. He will share valuable tips on writing radiological AI articles. And Professor Lu is also recognized as an outstanding instructor in our academic writing workshops. The second speaker, Professor Professor Eugene Lin is from Chang'an University and also serves as the Vice Director of Radiological Technologies in the Department of Radiology at Linkou Chang'an Memorial Hospital. His specialties are MRI and artificial intelligence. Professor Lin will present on the topic of AI-driven tumor segmentation and the radiomics in cancer MRI. He is an experienced researcher in this field. We warmly welcome and encourage everyone to join us at this conference and take advantages of this valuable learning opportunity, especially those are conducting researches or those are studying grad schools. Thank you.
Thank you so much, President Wu Kuei-Yuan, and we shall definitely save that date, July 30, for the 51st CPD Asia. Before I proceed with the closing, can I request a virtual clap? We have just